support we are providing to the facilities for learning and the districts. And in terms of additional support at the facility, we have developed a facility quality assessment tool based on the WHO standards. We have done some adaptation, and we're encouraging facilities to assess these standards with the districts. We are also encouraging facility placements for new skills we are developing, and also we are developing 4 skills labs. We have one which is running, and we are trying to establish 3 regional clinical skills labs with the support from GFF. Some of the facilities also have developed their WhatsApp groups, and they are managing their WhatsApp group, and they share experiences, they share photographs of what they have done, and so on, to encourage each other. And these are helpful at the facility level. At the district level, we are also doing exchange visits, encouraging some districts to go to other districts and learn. And then at the national level, recently we conducted a client satisfaction survey, which was done end of last year. And the main finding from this study was that only a quarter of the population is actually satisfied with our services in the sector. And there are more details to why they are not satisfied. And we're going to use this report this year to see how we can actually design interventions to make sure that we can improve client satisfaction. This is the quality of care standards, that tool we have developed for assessment. And the tool assesses the standards which we have adapted. It defines the requirements to assign the points, and also it guides you on how, and then there's a scoring system. So facilities are also assessing this in addition to the monitoring indicators in the framework, which they are also assessing. The other question was to share experiences from cross-learning activities, both at the district level and at the facility level. And at the district level, participants, we invite participants beyond the DHT, the traditional DHT team. We are including people like the political leaders, the biostatisticians, and the health unit management committees. And these are usually members who represent the communities to participate in this learning. And this has been very beneficial because sometimes the solutions actually come from them. The other experience we have learned is that if you have clarity and proper communication on the learning aims right from the beginning, and provide tools to ease people to do documentation, it makes it easier to move people into a culture of learning, so that it makes it very easy for them to understand what exactly this is about, and also encourage them to know that actually most of the solutions are within their means. At the facility level, we have also learned that homogeneity of the facilities, if you combine facilities at the same primary healthcare level, you have more participation and dialogue between the health workers, rather than combining hospitals, health centers in the same collaborative meeting. In some instances also, we have tried to invite non-learning facilities, and we've actually found that they've also benefited from these other people who are targeted for learning. So it's feasible to invite other facilities outside the learning districts. We've also learned that focus on a few specific problems is better, especially at the beginning. Focusing on a few problems which are common to all the facilities is easier than handling all the problems at a go. And this has enabled us to grow the process and add on things gradually. The last thing we have learned here under the facility is the identification of issues beyond the resources and funding. At the beginning, when we started these dialogue meetings and learning lessons, people tended to front the lack of funding as a big bottleneck. But with time, people have started now actually realizing that many of the solutions are actually feasible without many additional resources. But it takes time to move from this feeling that we need more money, but actually to find that they can actually reorganize their facilities and make local solutions. The barriers and facilitators for learning. We have mentioned one facilitating experience because we are just beginning. We've learned that having experienced learning session facilitators helps a lot. People who have done this before, we are borrowing people from other programs who have been doing some of these collaborative learning sessions, and it makes it easier when you have somebody who actually understands what quality improvement is about and what these aims can actually make. They guide the process much better, and they keep the whole things on course. Some barriers here. Collaboratives, which is our main learning method, withdraws staff from our workplaces, and it's occasionally costly. The high workload and understaffing in some of the facilities limits interpersonal or peer-to-peer learning at the facility, and then also sometimes the negative health worker attitude and district attitude towards learning has been a problem in some places. And of course, we have some complex chronic problems requiring efforts beyond QI, which sometimes harbor our process, especially the low staffing levels, the human resource challenges. Finally, this is my final slide about institutional support for learning. We have identified and negotiated with the Regional Center for Quality of Care in Uganda to support us in developing the documentation framework and building the capacity for documentation to do advocacy and also start thinking about program evaluation and the tools we might need. We are also going to work with Makerere University to specifically work on evidence generation for learning, focusing on bridging theory to practice, but we're also looking at working with other universities based on their comparative advantage, especially on learning on things like the clinical skills lab, but also modeling the healthcare service delivery model, which we think can promote quality of care most efficiently. Thank you very much.
Thank you. Thank you very much, Ministry of Health, Uganda. Now, I would like to request the representative from Ministry of Health and Family Welfare, India.
Good morning, everybody. I need to, thank chair and co-chair. And, before I start my formal presentation, I need to, discuss that how we have built up, actually, taken this forward under Lakshya, which was rolled out in December 2017, and tell you how we traversed the journey till now and how do we want to take it forward. So India is a country of 1.3 billion, 36 states and union territories. So we have already taken, certain initiatives, multiple initiatives like maternal newborn health toolkit, standardization of labor room, which is, at delivery points, that's basically, wherever the deliveries are happening. So district hospital, sub-district hospital, CSC, PSC, and sub-centers. Then we have this Dakshta, which is a training module, 3-day training module for focusing on intrapartum care and immediate postpartum care. Then we have a guideline or operational guideline for obstetric ICU and SDU. Then we have operational guideline on FBNC trainings. And then we have basically guidelines on kangaroo mother care. And we had certain existing quality systems in India that we have this Kayakal to promote cleanliness, hygiene, and infection control practices. We had national quality assurance standards, and these national quality assurance standards have been, already, been approved by the international accreditation. Then we have these quality standards for different level of health facilities and adverse effects of following immunization program. And we have this district hospital, we have 74 standards. CSC, we have 63 standards. PSC, we have 50 standards. Urban PSC, 35 standards. And AFI surveillance, 40. District hospital is at the population of 10 to 20 lakhs. CSC is at the population of 1,20,000. PSC, 30,000 population. So this is how we have these various level of health facilities. And we have the measurable elements and the checklist. We have a number of, maternal health and child health intervention already running. For example, Jani Suraksha Yodhana, we have Pradhan Mantri Suraksha Matritva Abhiyan and comprehensive antenatal care services. We have Jani Shishu Suraksha Karyakram. Then we have strengthening FRU and delivery points. We have to basically decongest, the high delivery load facilities. We have this MCH wing. The designs have been shared by, made and shared, and they have been made according to that. And we have added 32,000 beds. Capacity building of HR, that's Dakshta training, which is I mentioned earlier. Then we have this multiple skill training, which is, life-saving anesthesia skill and emergency obstetric care given to MBBS doctors. On child health, we have this 794 SNCUs, which are special newborn care units, 2,350 NBSUs, and 18,750 newborn care corners. Home-based newborn care, we have this 10 million newborn care every year, which they have been visited. Management of cases of severe acute malnutrition at new nutritional rehabilitation centers, screening and management of children with 4Ds. This is an RBSK program which covers 82.6 million plus children screened, promotion of breastfeeding, complementary feeding under MA program. This is the multiple initiatives taken by partners. We have Wash in Health, Model Labor Room, SNCU, Quality of Care by UNICEF, Point of Care Continuous Quality Improvement, WHO, Dakshta Asman with Japaigo. We are in initial stages of working on maternity information system. We have Safe Delivery application, which is basically supported by Maternity Foundation. We have Manata, which is a private, initiative for quality, which is supported by MSD for Mothers, Foxy, Japaigo, MacArthur Foundation. Nurse Mentors by BMGF and Care Around Birth by USAID and IP Global. So this is what, and then under the, basically the Lakshya which was launched, we have these very critical, key components that is focusing on labor room and maternity OT only, and organization and standardization of labor rooms, OT and obstetric, SDU and ICUs as per national guidelines and standards, structured quality improvement effort process to improve adherence to critical practices around childbirth, and of course, improve client satisfaction, that is respectful maternity care. And if the expected outcomes, outputs are that labor room certification, 75 achievement of target for quality, 80% satisfaction of beneficiaries. And if they get this, then you get the badges as well as the incentives, which is for medical college, we gave 6 lakh, and for district hospital is 3 lakh, and for sub-district hospital is 2 lakhs. And this will help in reduction of stillbirths, maternal, newborn mortality and morbidity, such as sepsis, newborn asphyxia, etc. These are the program framework. We have the baseline assessment using guidelines for labor room standardization, maternal newborn health toolkit, and NQAS. Improvement dimension, which is structural and process improvement, which is, enablers are labor room standardization, human resource strengthening, quality circle, rapid improvement cycles campaign. Outcome will be labor room certification, improve maternal and newborn health indicators. The governance, we have an institutional arrangement for quality, which is at national level, we have the Central Quality Supervisory Committee, state level, we have Central Quality Assurance Committee, District Quality Assurance Committee, and facility level, we have quality teams. The quality drivers will be national mentoring group at the national level, state mentoring group at the state level, and coaching teams at the district level, and quality circles for labor room and OT. Now, coming to the key elements, the selection of high case load facilities, including medical colleges, we have 2,100 facilities have been identified, and national and state orientation have been done. Baseline assessment and gap analysis is being done, then state certification, national certification, and there are 20 quality monitoring indicators which are to be basically monitored, and if they achieve that, they get the various incentives. Medical college rollout in partnership with Apex Institute like AIMS, web-based monitoring, standard operating procedures for medical colleges and district hospital and below. And of course, Dakshta training, OSCE-based assessment, skill stations at facilities, birth companions, different birthing positions, focus on RMC. And of course, these Mera Aspatal and Gunakap. Mera Aspatal is for, finding out patient satisfaction and engagement of all stakeholders and division of areas. These are the 6 quality improvement cycle. The cycle 1 is on documentation, cycle 2 is on respectful maternity care, cycle 3 is on timely management of complication, and cycle 4 is on judicious use of oxytocin. Cycle 5 is on essential and emergency newborn care, and cycle 6 is on infection prevention and biomedical waste management. So this is the website which is already in final stages of preparation for Lakshya, the way forward and learning. So way forward, we are actually, rolling out midwifery services and CADAs. We are going to start by June. CADA or midwives skilled as per competencies prescribed by International Confederation of Midwives. Revision of current, we already have some, curriculum on nurse practitioner midwifery, which is going to be revised to 18 months curriculum. And we will have midwifery-led unit in public health facilities. And of course, certification and regulation by Indian Nursing Council. We will have maternity wing management information system, clean and green health facilities, and quality assurance framework for PMSMA. And Central Quality Supervisory Committee will actually take this Lancet collaboration on quality and basically taken forward. The key learnings are synchronizing existing initiatives and developing partnerships. This is my last slide. Judicious mix of all approaches, assurance, improvement, accreditation, and certification and licensing, explicit measurement certification system, institutional arrangement for quality, linked with financial incentives. The key challenges are ensuring documentation, infection control practices, inculcating analysis and use of data for action, infrastructure upgradation in high caseload facilities with lack of adequate space, and of course, sustaining quality standard post-certification, and of course, motivating HR and sustaining motivation. Thank you very much.
Thank you. Thank you, Minister of Health and Family Welfare, India. So we have had three great presentations from the three panelists. So now the time for partner reflection. So I would like to invite the dais, Dr. Chamar, USAID, Dr. Peter, McCare University, Dr. Samsud Joha from WHO, and finally Ms. Caroline, Lidl Global Health. Okay, thank you. So still we are running behind the time. So I would like to request our partner reflection to shorten the time, and the maximum time might be 3 minutes. So first I would like to invite Dr. Tamar from USAID Assist URC.
Good morning, everyone. My name is Tamar Chitoshvili. I'm leading maternal newborn child health portfolio within USAID Assist project implemented by University Research Co. I just want to get back and remind everyone that the learning system is one of the key 5 components we discussed these last few days that are designed to support continuous quality improvement. And this is a part of the essential function, core function to sustain and scale up improvement. So when we discuss this, so it's critical to understand what we learn, right? And the Uganda team has very clearly outlined what are the key components of the learning at the different level, right? At the facility level, we need to understand what changes work, and also we need to understand what changes don't work, right? Because that would allow us to save some time and resources to test unsuccessful changes. At the district and national level, we need to understand which facilities perform well, which need more support, and provide target-based support to those health facilities that need more support. And at national level, we need to really understand what are the successful changes that need and can be scaled up and how to sustain it. So there is a learning at every level. So in addition to what we understand and we learn from what are successful changes, we need to understand also how it is being happened, right? Because what is important part, but also how gives us and gives teams more understanding how to implement changes, how to understand the problem and apply different problem-solving tools to really understand what is the root cause of the problem and apply the solutions that would be like reflective to the gap identified, right? And we have identified and we have learned that this is the most critical and challenging part for the teams to really employ these problem analysis tools and identify the problem that is reflective, because the teams usually try to jump into solutions, predefined solutions to improve inputs, to improve knowledge and skills, but sometimes the problem is the poor processes of care, right? So it's very important to really understand what's the problem behind. Given that what and how, there are different tools that our countries outlined very well and can be used for this purpose. For example, like they mentioned documentation journal, right? They mentioned bulletins that can be used to document these successful changes. There are also the format of case studies. USAID Assist project has developed the case studies for multiple, different purpose. For example, single improvement team case study, single facility case study, multiple team case study that would allow respective learner to understand how and how this has been done and what were the contextual factors that the teams teams try to overcome. In addition, there was a discussion on the availability of the tools, especially in terms of routine monitoring tools that allows to document how the improvement has been achieved, plot the run chart and annotate this run chart with specific changes. And there are also the online platforms available that can do the same. USAID Assist project has developed the largest online database of improvement indicators that allows health facility teams to enter the data for specific indicators and also plot and document the changes per each improvement measure, and also there is a different levels of access. There is access for coaches. They use this data to identify which facilities need more support, to provide target-based support, and also there is access to the national level policymakers to see how the system performs and what learning can be drawn from these improvement experiences. What are successful changes that have been tested and implemented by sites, and what districts and regions need more targeted support. So these are some key reflections. Also want to highlight importance of the national level learning. Both Ethiopia, Uganda have done amazing job in terms of summarizing and compiling learning through the national bulletin. I had also privilege to be part of the National Quality Improvement forum that is happening every year in Uganda and brings together hundreds of experiences from different QI teams and hundreds of lessons learned from these changes tested and implemented in each country. So congratulations to these great teams, and there are systems in place, but there are challenges to to be addressed. One of the major challenges that we witnessed a lot of time is that this learning cannot happen if there is a fear to share the problems, if there is a fear to like openly discuss this change. And this could happen in many different settings, even in high resource settings. We have recently been in part of this like Eastern Caribbean work, and the results have been used like by key decision makers to promote some of the teams, but also to diminish the work of the teams that, and they were specifically emphasizing the teams that were consistently underperforming. At the learning sessions, we always emphasize that this is a judgment-free zone so that everyone comes openly discusses the problems, but these teams were demoralized because this information and data were used for public shaming of these health facilities, among others. So it's very important that we emphasize the judgment-free environment to have the possibility to learn as much as possible, even from unsuccessful changes. Thank you.
Thank you very much, Dr. Tamar. Now I would like to request Dr. Peter from McGill University.
Thank you so much. My name is Peter Waiswa. I am an associate professor at McGill University in Uganda. And I've been doing quite a bit of QI, especially doing implementation research, which we've done in Uganda and also in Tanzania with Tanya, who is here. By the way, I have a handout about one of our projects, which is on the table. It's about the preterm birth initiative, where we've documented what needs to be done in QI, what have we learned. Now, having said that, I really like the presentation from the three countries and what they are doing. I think they bring a diversity. I've been thinking Uganda is so big, but then we have Ethiopia and then India, and the scope of implementation that they have and what we learn from. So in my reflections, I want to start by learning from what they have done, that we need to align this learning, the quality of care learning, to actually the national goals and the international goals. And for me, these are the UXC and SDGs. So as we do this quality improvement, we must ask the question, is it facilitating countries to achieve the goals that they have already actually set? So that's quite important. Start small, but there's no time. We must run and be able to scale up. Like Margaret said the other day, we must scale up with quality, which is the focus of this. So that is number one. And I liked the scope of implementation in the three countries. The second one, which I've learned from here, and which I've also seen in the field, is actually the foundation of QI, or quality improvement or quality of care, is actually leadership and management. Leadership and management at all levels, that is at the national level. We've seen this in all the three countries, at subnational, at the district, and even at facilities. So far, I'm not seeing so much of communities. We've actually did a project called EQUIP in Uganda and Tanzania, where we had a quality improvement system at community level and embedding this with facilities and districts. So I think this is one area that we should be moving into, especially if you're going to do the part of accountability, then you must empower communities. And therefore, finding a way of doing quality improvement at that level is important. The third point, I had a number of points, but I'm going to jump because of time, is the need to have comprehensive packages. Again, we've seen, especially what I've seen from India, there are quality improvement initiatives. It's not just the quality improvement or the PDSS cycles and stuff. It includes a lot of things, the quality assurance, the standards, the accreditation, and the skills. And all these are going to be critical, and we must document them in our learning and to see what are the critical aspects that are needed in order for quality improvement to work. Which brings me to the other point, that in all these initiatives, for the WHO and the partners, the guidance is that we should reduce mortality by 50% in the facilities. But I didn't hear countries actually mention this. And I was a bit happy about it because a focus on reducing mortality in facilities is actually very discouraging and also can be very difficult. I will give you an example. Reducing mortality in facilities, especially in our systems, is a challenging thing. When you try to improve quality, you actually have a feedback mechanism. Many people come in, and many times the resources don't increase. We don't increase the number of health workers, we don't increase the drugs, neither do we increase space. In one hospital in Uganda, 8 years ago, they used to deliver 3,500 mothers a year. Today, they deliver 7,000. So now what has happened is more severe cases are now coming in because they have learned that this hospital does a good job. How do you expect that hospital to reduce mortality? So let's focus a lot on the change ideas and the measuring quality, things we can celebrate. And then later see, is mortality reducing? And if it's not reducing, to be able to understand why. So that's, for me, an important thing. Which countries are doing? They are focusing on what can we do, is quality improving, then later they can see, is this resulting into mortality reduction? Finally, the last 2 points I wanted to focus on is that QI must be managed. And again, the 3 countries are demonstrating that by beginning with QI teams at national level, at different levels. I just wanted to bring to attention of an initiative I was involved in, which is the Saving Mother Giving Life. I was actually the country PI for Uganda. These papers are being published today in, I think, the USAID Journal of Global Health. And in Uganda, it led to a 45% reduction in maternal mortality. But the implementation of this was done by partners, by 2 NGOs in Uganda, with support from PEPFAR and the USAID and others. But right now, actually mortality in these places has gone back. In one of the hospitals, it has now, I'm told, the highest maternal mortality in the country right now, consistently. And why? Because the district systems were not able to take up what the project was doing. So we were able to reduce mortality because it was managed. But if we don't manage the QI system, like right now the systems are weak, then we are not going to have impact. So whereas we learned from what SMGL did, then we need to go back now and say, what is happening now? Is the reduction consistent? So QI must be managed, and many times government systems are not that strong. They need to be supported in order to be able. The last point, which I was actually very happy, thank you, Jessica, who is from Uganda, he said they're going to work with Mackay University and other universities. I think this is important. We work with them. I hope we can even become stronger and also learn how to work together, because documenting QI, documenting the learning is actually quite complex and not everyday business that implementers can do well. Thank you so much.
Thank you, Dr. Peter. Now I would like to request Dr. Samsujosa from WHO.
Thank you, Chair. Good morning, everybody. My name is Sham Said. I'm responsible for quality health services at WHO headquarters, and I oversee the WHO initiative on national quality policy and strategy. But most importantly, today I'm really privileged to be a part of the QED network from the inception, which has been a huge privilege and a learning opportunity in its own right. So I know time is very short, but I really enjoyed listening to the country presentations, and just to pick up a few of the points that really resonated when I was listening to those presentations. So with the Ethiopian presentation, it was clear that the Ethiopian authorities have developed an organizational structure for quality. And I think that's a really important point to learn from about how learning needs to be embedded with a clear direction and organizational structure for quality. And that was clearly articulated as the basis for intra and inter-facility learning. And that really jumped out. The Ugandan experience is huge, clearly, and multi-year, I know. And again, the Ugandan team emphasized the enabling policy environment required to support the learning that's taking place. And making Ugandan experiences available to all was particularly noteworthy. It's something that we could also learn from, how we share the learning that's emerging from each of these country experiences. But one particular point that really jumped out was the use of satisfaction and thinking about learning to enhance that satisfaction. So that figure of 25.6 satisfaction, 25.6% satisfaction being placed at the heart of the learning and really trying to push that satisfaction through learning. And in terms of the Indian experience, of course, huge, it's very difficult to unpack such a vast experience, but the quality architecture is vast. And the institutional arrangements for quality, again, are being placed at the forefront. The one point to emphasize also that jumped out was the role of specific needs for learning for specific cadres. So the initiative focusing in on midwives and really focusing in on that as a new area for fit-for-purpose learning on quality. So those really jumped out, and I just have three reflections from my side, building on these points. So the first point that I'd really like to emphasize is we need to take a systems approach to learning. So it's the utilization of a clear national direction on quality as an overarching frame of reference for learning is really important, and not ignoring and creating a clear balance between learning at the national level, sub-national level, facility level, and community level. But placing particular emphasis, and if there is an emphasis point here, it's always going to be unfair to place an emphasis on one of those levels than the other, but the district as a unit of analysis and a unit of action for learning is a really important common denominator for learning that can activate action, because learning is for something, right? So that is something that I really wanted to emphasize. District-based learning and connecting that learning with the delivery of essential packages of health services. And this really does link in with the point about UHC that Peter eloquently made. The second point that I wanted to highlight was that we need to prioritize learning between technical programs so that we avoid a siloed approach to quality, quality MNCH, quality HIV, quality XYZ. It's quality learning for the entire system, and of course there are pathfinder roles that any of these really impressive areas can provide, but it should be quality of health services for the population, whichever population it is, and whichever technical area is used as an entry point. And that cross-learning between those becomes critical. So when developing learning systems, thinking about that right from the beginning. The third and final point is learning from people. So when we talk about learning systems, sometimes we do forget the wisdom that exists within communities. And if we think about the quality world, a lot of the solutions for the wicked problems that we face in health facilities and in subnational systems, the community has wisdom that can be tapped for learning, and we shouldn't ignore that. And they can develop solutions. They're not just they are not just a source of complaints. They're not just a source of problem identification. They can develop the solutions and co-develop those solutions with the system. So when we are thinking about learning systems, and as we move into the next iteration of our learning systems, let's also remember the wisdom that exists within communities. Thank you.
Thank you, Dr. Sams, for your excellent observation. So finally, I'd like to request Ms. Caroline for Leader Global Health.
Thank you very much. First of all, I would like to also thank for very nice presentations, and I've certainly learned a lot this morning. My name is Caroline Linde. I'm the Managing Director for LADAL Global Health. And since 2008, LADAL has worked with partners in the Survive and Thrive Alliance to develop transformational education programs with an including a focus on quality improvement and a guide and training for quality improvement teams. So for us, our main focus in the quality and where we have been able to contribute has been on the capacity building of staff and training. But I would like to spend time commenting on the presentation. I thought it was really interesting, and as my colleagues have said here, a set of diverse presentations that is a good inspirations for other. I thought Ethiopia shows again the strong leadership that they take from the government level, the way they're able to harmonize the implementing partners and leading them so that they're all working towards the same goal. I would also like to commend Ethiopia for also including a lot of the local implementing partners and the professional associations. It was not mentioned in this presentations, but I know that they play an active role in this, and they are always being taken on board, which is crucial for sustainability. Again, Uganda, I would love to learn more about the systems in Uganda. I also really thought it came through how you are using innovative measures, for instance, the data systems that you mentioned, but also including the institutions that you already have in the country that has specific capabilities. It was mentioned clinical skills labs and using the capacity in Mbarara, and I had the opportunity to visit Mbarara. They did a conference on simulation last week, and I was utterly impressed of how much they are able to do with essentially quite little resources. And to use that in building your other clinical centers with the support of GFF, I think it's very smart. LADAL has traditionally been working a lot in emergency medicine, and in emergency medicine we often talk about the chain of survival, which is about early recognition, early initiation of treatment, and early referral to advanced care. But what we are realizing more and more is that this chain of survival actually needs to be within a framework of survival to work. You need to have strong leadership. You need to have quality training. You need to have quality improvement measures. And you need to have a culture of excellence. If you don't have these things, your chain of survival has a lot less chance to work. I also would like to point out the mention of harmonizing the mentorships. And I think this was Ethiopia that mentioned. I think that's a very good idea. I think quality improvement really needs to go together with the capacity building of the clinical staff. So having the clinical mentors and the quality improvement mentors or coaches being the same people, being part of identifying the gaps, but also being part of the solution, I think sounds very, very smart to me. There was a mention of sustainability, and of course everything that's ingrained in the government system has a lot more chance for sustainability. And it saddens me to hear the story from Uganda, from the Saving Mothers, Giving Lives, where you showed such an excellent result, and then you're not saying that the facilities have not been able to maintain this. We really need to work on that. We need to move away from doing pilots, but to build in these kinds of programs into the government systems. We need to measure to improve, it's been said before, but this is also about sustainability and going beyond. It was mentioned by India. How do we ensure that when we've certified someone for their you got the quality stamp, how do we ensure that they are continuing to improve? And measure, improve, that defines the essence of ongoing quality improvement. And at the end, I also wanted to say that I think it's fantastic to see that so many countries are capitalizing on the digital revolution. We had an amazing presentation from Uganda yesterday where they were showing the dashboards from the DHIS2. I mean, this is really going to revolutionize the way we capture data and the way we're able to feed back the data to the users, to the mothers, to the communities. And I would like to say to anyone that has problems with people putting in their own data systems, you don't need to accept that. DHIS2 is an open source. You can demand from anyone who has their own apps or their own systems to align with that so that you get it into your own dashboards. That's it for me. Thank you so much again for an amazing conference.
Thank you, Ms. Caroline. So now we have enjoyed the 4 partners' observation. Actually, they have, I think they have properly articulated the key areas of the panelists that they have presented in the session. So now this is the time for Q&A, question and answer. So as we are running behind the time, so we have to going to cut up some areas. So I would like to request my co-chair, Dr. Anna, to conduct the session, question and answer.
Thank you. Good morning. Thank you, my co-chair, who has conducted a very nicely meeting, and also taking into account the time frame. But also, before I invite the questions and the answers, I would also reiterate by saying thanks very much for the presenters who has presented more information to us, which is very rich, which will also articulate to our areas, and also the partners' reflection, which also has been reflected on the presentation, which I'm not going to say much on it because it has already been said and stressed. Therefore, we go straight to the questions and answers. As my colleague says, the time is not to our side, but we have to do it. I would like to ask members from the floor who will have some questions from the 3 rows, if there are those who are ready to have questions that they have to, then I'll take few because the time is not to our side. Start from that end. Maybe we raise our hands so that I know. From this side, how many? Who is ready to have any question from the reflection? Okay, Alex.
Yeah, thank you. Great session, great panel. This is really more of a comment than a question. So one of the things that characterizes the change that's been happening over the past kind of decade is this movement away from kind of just training as a key mechanism or approach to improving quality, and there's a lot more sophistication. That's fantastic. My comment is, as QI is being implemented and scaled up, I keep hearing training on QI, and I just wanted to remind everyone that this was a problem before. One of the reasons why we're using more nuanced, sophisticated ways of improving quality is we were trying to get away from training by itself, which we know we have hundreds of studies, and I'm happy to share my list of hundreds of studies on training. So we know that it's not really the best way, and I just hope that people who are in scale up, because that's sort of what's going to happen over the next 2 years, keep in mind that training is helpful, but training combined with other things is almost always going to be more, have a greater effect. Thank you very much.
Thanks for the comment. Is there anyone? This side? Okay, 2 people from there.
So, this is regarding learning, and learning at a certain level is very important, where one initiative on doing quality improvement at scale in a country or in a region tries it, but when another effort is planned, what did not work in the last effort does not go into planning the new effort. Different partners, different agencies in different geographies do keep making the same mistakes again in terms of setting up systems for quality improvement to happen. So that loop we will need to close. There's a lot of efforts at improving quality at scale. Unless we keep learning from them and keep closing that loop, and such learning mechanisms are available, we will keep making the same mistakes. Thank you.
Yeah, thank you. I think mine is to the learning group. Still, the use of terminology, common terminology. We noted that we are using coaches in some places, supervisors, champions, quality champions, mentors. It's time maybe we agree and have one nomenclature, because it confuses on the ground. Some are training champions, others are training mentors, some partners are training the various sort of names. So I think it's bringing confusion. It's something we need to work on. Thank you.
Much, okay.
So thank you for a great session. I believe building on what was discussed yesterday during the 2 sessions and this, it all boils down to whether do we have, and it's a complex system which operates. You have training, you have mentorship, you have quality improvement, all needs to fit into a big basket, and each has its own role. But I believe everything boils down to the resources which we have at our disposal. And there have been challenges on the financial front, which I believe have been showcased or brought forward by each and every country. So as a group, do we feel that over the next 2 years, or as the network moves forward and expands, do we have the financial resources, and do the countries now take it upon themselves to function as leaders with partners acting as catalysts to take the movement forward? Because all this is resource intensive, so we need to have certain parameters which are taken care of before we move into more results and improvement. So just a thought.
Thank you very much. I think we have heard from the questions. And now the last one.
Thank you very much. I thank all the presenters. And I have a question for the presenter from Ministry of Health and Family Welfare, India. I'm much interested to know and to learn a few things about the way you manage respectful maternal care. That is the area where I am interested in. And you have shown that you are trying to measure it using client satisfaction, and you have even a target there, which is very good. But my worry is respectful maternal care is really a very broad area, and it cross-cuts probably across 3 standards in the quality of care. And there are a number of indicators there, quite a number of them. But 3 or 4 of them actually directly relate to how quality is experienced by the mother. And those questions, if I put it to the mother, say if I am the health worker working in there, the mother may not be comfortable to answer it to me. You know, it has to deal with health workers' attitude, how health workers supported her during her stay in that ward, what kind of emotional support she got, and did they treat her with respect and dignity? And if I put this question myself to the mother, she may not be comfortable to answer it really the right way. So how do you get those information from the mother? How do you collect those kind of data? Who does it? Thank you, and it was really a very great presentation.
Thank you for the question. I think we have progressed, quite a lot in this direction. For example, in the Mera Hospital, which is converted into, if you convert it into English, it is called as My Hospital. So a feedback is taken once the, woman is discharged. And then we ask certain questions on that specifically. Now, one of the questions, let me tell you, is that we already have introduced birth companion into the facility. Now we have 22 states which are already, delivering and have a birth companion in place. The questions which you are asking about, we are also following what are the charter in the, White Ribbon Alliance. All those charters are part of our guideline. And we are sensitizing both the provider on the aspect of, abuse and all those things. So whenever we are holding these regional meetings and basically state meetings, we are actually, making it a point to sensitize them. We are also, making a group of people. One of the thing which is very important is that normally the delivery happens in the lithotomy position. We are giving an option to the woman to deliver in different positions. Now we are also having a group which will deliberate on that and see that how do we take forward. Thank you.
Thank you very much. Thanks for the questions that has been provided together with the answers from our audience. However, which has been said mostly from the comments from the questions, that we all see that the issue of learning systems that we need more to inculcate and see it. Some we know that really we have documentation that we do. It will depend with this transferring of the knowledge at different levels. That's why we find there are a lot of things that are being done. There are studies, they might be good with the objectives and so forth, but you never find people, maybe they don't have access. Even if they have, they don't have even time to go through it. But we find that it's nice, but it doesn't reflect and transfer the knowledge. However, we know we have the word training everywhere. It is a soft tissue that we need to deliver. But always many people would like to use training than giving you anything which will reflect apart from the training. That is, you translate anything training, but without knowing which heaviness of this training goes. But we are saying, can we move from another way? But again, we are seeing people can interpret training in a different way. If it is coaching, if it is studies, if it is a bullet, it is in the form. It will depend to each type of form of knowledge that is being transferred to change our things. Therefore, to me, I see again that within this one, which we have seen, there is a lot of things that we understand and we know. It's a big basket, a package of things that, again, we need to unpack and see which really will be focused and be directed, but in a simpler manner. We have learned from all the countries, there's the issue of shortage and of human resource is a big challenge. But we would like the same person to do whatever we have discussed since day one to date. But again, we have a lot of things that we need one person to help. At the end of the day, we need to translate the data into practice to outcome that we need to get out the health service delivery at the end of the day to reduce maternal, newborn, and child health, our indicators and suffering. But still, we have a way to go. Since we have heard from the morning, on site what has been presented for all the countries. Again, we looked in terms of data. All the countries, what to do, what to learn. But there are still other things which are coming. But again, there are other things when you see here we are doing, someone is getting a chance of capitalizing where is the weakness, where is the entry point that I can enter. This is a world moving. So we need again to look to see which is the best way to try us. Although we cannot complete or finish, but we need to start somewhere which we can start to move. Thanks very much for the time taken. Thanks very much for our panelists, for our partners' reflection, and for all of us being here and sitting. Let us clap ourselves and give a clap.
Thank you, my co-chair. Before going to the working group session, I would like to invite Nigel to brief the tour of the group work. Yes.
Thank you, Mr. Chair. We were consulting with the Secretariat, and given that we are running late, we would propose the following change. We go on coffee break till 11 o'clock. Okay. 11 o'clock, based on your letters and working groups organization that you have in the program, please go to your working group room. We will have the working groups for 1 hour only, from 11 to 12, and we're coming back in the plenary at noon. Is that okay? So at noon, we'll have the 1.5 session on program management, and lunch will be served at 1:30 instead of 1. So we'll shortening for half an hour the working groups, and we will postpone the lunch with half an hour.